definite role for DEB, which is scoring balloon, particularly if they have high-risk ISR, posterior lesions, repair well, and then use DEB to make it more effective. Thank you, Vanida.
Thank you, Dr. Sridhar.
Thank you, Sridhar. There is a small change because the international live transmission is coming up. We'll have the live case first, and I requested Akasaka to deliver his talk after the live case. So I request, you can continue. I request the chairpersons for this session, Dr. Sushil, and in place of Saurabh, Dr. Ajay Kirtan, also to join the panel. We can continue, sir. Then other panelists, Dr. Shantanu Guha, is he come? Dr. Soumitra Kumar, please join. And other moderators, Dr. Pramod Joshi, B.L. Agarwal, Rajiv Bharadwaj, Parminder Singh, Sanjeev Sharma, Hariram, please come out to the stage. We have international live transmission coming up from Antonio Colombo. We are very eager to watch him. They always do a wonderful job. And afterwards, we have lunch and then tower lectures. But immediately after the case, we'll have Akasaka deliver his talk on imaging. Over to you, Dr. Sushil, to take over. I think we are having pictures from it. Over to you.
Okay, so
admitted in another hospital where he was refused therapy and he was left there, you know, he was practically going to die. He had severe heart failure and his family was desperate. The son came to Milan a week ago, showed Antonio the angiogram, and then the son put him in a car and drove in, I think, you know, 800 kilometers from the south of Italy to the north so that we could try and do something for his coronary artery disease. So let's hear what you think.
So, Sushil, first of all, thank you for having us with you. I think you heard all the details, and basically, I think with this amount of calcium, you can try balloons, but I believe to do intention to treat heart ablation is appropriate. It's not a must, but I would say is appropriate. Considering the low EF and the extensive work that needs to be done, balloon pump or impeller to be more updated is the best. Okay, I think enough for us to talk.
Can we ask a couple questions, Antonio, real quick? Can you hear us?
Yes, sir.
So, impeller...
Yeah, I can hear you well.
So, it's the choice of impeller versus balloon pump. Based on hemodynamics at all? Is it the overall EF? Did you look at the right blood pressures? How do you make that decision?
But recently, I must say that when you have low EF and you plan extensive work, we prefer impeller. We have been really switching. We only use balloon pump when it's very intermediate, when there is some vascular access issues. But in the last 6 months, I would say balloon pump is mainly for emergencies when there is not the impeller stuff available. But if you can make a choice, I think even the impeller, a smaller one like the LP, it's okay. But I think we prefer.
This is the CP with 4 liters support?
Yes.
Yeah. Well, 3.5. You know, we had a lot of discussion, Sushil, about a bit of discussion about 2.5 or CP.
While we talk, just to save time, I keep on going with the heart ablation and we talk.
And
so let's go without magnification. Togliamo la magnificazione.
So the fact here, we're going to do probably the left main LAD rotablator and probably the right as well. If things go well with the left, we thought we wanted better protection, and that's why we chose the CP. Do you want to go with the spin?
It's okay. Some people go like this, how I'm going, and some other people go to Rotaglide.
With Dynaglide?
Dynaglide, and they go down with Dynaglide. It's okay. Dynaglide is a little bit easier because you don't have...
What about orbital?
Okay.
Yeah, I think the challenge with just an orbital is
Not
the osteum. That can be an issue. Go ahead, Antonio.
Okay, we don't have orbital atherectomy in Europe, so for us is not an issue.
Yeah.
Okay, so this is a 1.5 burr. I'm going to start from here because
You like super high speed to see the console at 220.
yeah, it's a little bit. We can lower the speed.
Yeah, let's go down.
We can lower the speed.
Let's go to maybe 180,000.
180. There's no reason to be. Abbassiamo un po'.
It's okay.
I think it's
Transmitting
good.
to Asia, it's okay to go 220.
Go down, andiamo giù, giù. Giù, giù.
So Ajay, you've got a lot of experience with impeller. Would you use CP here or the 2.5?
Yeah, no,
Okay.
rarely use 2.5 because they really only save one friend size with the access. The other thing too is that, you know,
Right.
I guess I grew up watching folks like Antonio do these cases with balloon pumps, but I have to tell you, it can be done, but it's just so much calmer, and I think it speaks to what you said in the last 6 months of time earlier. It's so much calmer to actually use full support like this.
Okay. I think it's enough.
And I don't know.
think it's enough.
The cost is
Okay, let's pull it out. Mi dà un pallone non compliante del 3 lungo 20? Okay, we are ready to remove the rotablation. I think with the soft rotablation, it is not really
Yeah. Can you add to that?
required.
Yeah. And the pressure really remains very stable. And our concern is always if they get distal embolization with rotoblade and we don't only have a balloon pump, it can really be a mess. Just hang on a second.
But you know, if it's not a must to use impeller, you could do with balloon pump quite okay.
And if you're doing the blue pump, you have a lot of cautious, shorter run, retreating for blood pressure, things like that. The problem in these cases is that maybe the blue pump without support, you get that little bit of ischemic spiral, it is hard to reverse.
Yes,
yeah,
yes.
absolutely.
And I believe, I think no reflow or slow flow tends to occur less frequently. You want to take a picture?
Yeah, second little pictures, make sure there's no complication.
Let me go in with the guide a little bit more. There is a little bit of spasm in the radial. Un piccolo test. We are a little bit outside. It's a lot of spasm with the radial. That's the drawback of the 7th French. We're going to have problems here. Andiamo con 20 di campo. Yeah, but still, it's not really 6 French slender. Let's take a picture. You're going to see a suboptimal picture because I cannot advance the guide. Pronti? Via? But it's okay, everything is open.
Everything's good, there's no...
What do you want to do for the very distal LED?
And then maybe either nothing or maybe some drug-coated balloon. Let's see what the proximal vessel looks like after we've dilated. And also we need to make a decision, and we'd love your guys' help about the circumflex and what to do with the circumflex. I'm very for being provisional on the circumflex, but we'd love to hear what you guys think.
So this is a 3O balloon?
No, this is a microcatheter, so we can change the wire.
You want to change it?
Yeah. No.
Okay, we could have walked on with the rotablator wire.
Well, you know, we have radio, we don't have great support, so the guiding catheter. Okay, yeah.
So, tell us,
wire?
you decide when you're going to rotate the circumflex, because this always comes down to Sheila actually had a discussion just about a week or two ago. You have to hold the LED wire, but yet there's calcium to the surface.
I'm going to guidare nuovo. Non questo. La guida nuova, 2 per fuori. Universal.
I think, let me come out with the guide. It's a little bit low blood pressure. I'm not going to rotablate the circ. I think I don't see a lot of calcium in the circ. There is some calcium, but I will see how it dilates and only rotablate if I really need. But if I have difficulties to advance the balloon, I will not go to very small balloons. I will switch and rotablate. So we are removing the rota wire and going with the universal BMW.
Andiamo a 25 in rendimento. Let's go to 25. Okay. And can you give me the inflator? Let's do an enter.
Okay. So this is the next step, but I think we remove this with the,
Aspetta.
Yes, sir.
A trick that we like is that for this step, if you put a wiggle wire down, you don't have to hydroplane it or trap it, because the wiggle wire stays anchored distally, and you can just remove the microcatheter without hydroplaning or trapping.
It's okay. Okay, so this is the 3O balloon. So
you want to put a wire in the circumflex?
Not. Okay, let's put a wire in the circumflex. It's fine. Mi dà un'altra universal. So we can. We have a 7 French. It's okay, even a 6 French. So how far do you want to dilate with the balloon? You want to dilate inside the stents?
So let's look at the pictures again. Let's show you
Can
the
we
angio
see?
again. Let's see the cranial too.
Let's decide.
Let's go back and see the cranial.
How-
Okay. So I think we can stop just after the septal branch.
I
What do you
agree.
think, Sushil?
Yeah, no, I agree. I would say maybe just barely into the proximal edge of the stent. Are you going to IVUS after this?
Yeah.
After this dilatation, or what's your?
Yes,
So
I think we're going to
I
IVUS,
think
but first we're going to stent. We're going
We're
to
probably going to do IVUS at the end.
Mettiamo a 20 di campo.
Okay. Piccolo?
So we're going to go in DOM.
Step just to
Yeah.
protect the circumflex if you're going to stent across it. And then the other step too that sometimes you see omitted is the non-compliant balloon in the vessel that has been
Test.
or atherectomized. Very, very important because if you don't see it expand, then Antonio will go back with a bigger burr. But in this case, I don't think he's going to need to. I think it's
That's a small branch.
That looks better? That's it. Excellent. Great. Okay,
Okay, so
so
we leave the torque on the circumflex.
balloon?
The guiding catheter is behaving fine. We don't have any damping of the pressure. I mean, even if I have the impeller, I don't like to give global ischemia by occluding the left main with the guiding catheter, so I pay attention. Okay, so this is a trio non-compliant balloon. Let's go in cranial, andiamo nella craniata obliqua destra, poi AP. So we decide
Okay, come back
not
a bit.
to go inside the
From there.
stent.
No, just from the edge of the
Okay.
stent. Okay.
Let's go to 20. Our nominal pressure is 20.
that seems to open nicely.
Yeah, very nicely.
Okay,
Okay.
down.
Safe.
Again, this is the difference between the impella versus
Right,
others.
this is-
Is he can go up and stay up a little bit and then come down.
Puoi tenere la pressione sul schermo anche, signor Ali?
I think with
That's-
yeah,
okay.
the pressure
Okay.
with the balloon pump or without
20.
it, this would be a lot more up, down, up, down.
You see how the blood pressure goes down? 20, 20.
20. Yeah. So here we've got like the whole left system closed.
Still is not completely expanded. Go to 22, 24.
So look at that blood pressure tracing in the upper left.
That's better.
Okay, down.
Yeah, I mean, without the impeller, we'd be
We
now
did.
at 20 of blood pressure. I mean, with such a long inflation.
Let's do a quick inflation in the left main, then we go down. Go up.
Yeah, you can, I think it's
And also the difference is the recovery between inflations is much quicker with impeller.
Okay, down. Let him take a breath of fresh air.
Let me get this balloon out as well. It's damping the pressure.
Yeah, but it's coming up.
Then I see the pulsatory.
Yeah.
And Antonio, the comment you made
It's really,
that no reflow is an important one too, because of decompression. Theoretically,
andiamo a 25.
pressure to the ventricle is better than if you did not have an active valve in the ventricle.
Definitely molto distante.
No, but it's okay. I think it's in this view look. Approximately with the 3.5. And then
Let's look at the pressure now. You know, the recovery between ischemia caused by inflation is just incredible.
yeah.
Have you had
But you know, we did,
None.
No.
None.
we did these cases 20 years ago, even without stents.
We just balloon angioplasty.
Yeah.
And someone doing cardiac massage at the same time.
What is technical plastic earlier case? AS patient with MPAV
Let's go there.
theoretically work, but you wouldn't want to give it then a
15.
try doing IFR. I think in general,
Andiamo a 20 di campo.
then probably I would
18.
Okay. This is a 3.5 balloon, well expanded, down.
La pressione sempre, signor Ali?
Let me go more proximal. Okay. Go up, 20.
And we didn't talk about the bifurcation. What are
We
your
can stay up a little bit.
bifurcation? IVUS first and then
Yeah, that's I think we're gonna be provisional and then decide. Down.
that's very
Yeah, I'm going to stent left main to LAD.
Look at the blood pressure. You get the balloon out. He's recovering, but you know, despite the CP,
Well, that's why I think, I mean, CP impeller is better than balloon pump in these cases.
The patient is sedated but awake.
Awake,
yeah,
yeah,
patient
yeah,
is
no
awake.
sedation.
No sedation.
He's awake with local and
When the pressure goes down, are there any symptoms?
No, tutto bene? Patient says that everything is fine. Tutto bene. Tutto bene means everything is fine.
So we're going to stent.
Let's take a picture. Let's go into spider. Spider.
Yeah, so Ajay, we're going to be using a Indian-made and designed stent today in this patient. We're going to be using the Bluminous stent. So I'm not sure if you have factoids there that you may want to bring up.
It's a little bit not, unfortunately, maneuvering this guiding catheter. Piccolo test, appena appena.
That's better. That's better now.
Okay.
Okay.
I think we need to dilate the circumflex.
Lost in the circumflex.
Yes.
2.5 balloon?
Yeah,
You wanna go
2.5, 2.5 non compliant, 2.5 non compliant, 2.5 non compliant, pallone, lungo 20 va bene. So we predilate the circumflex with 2.5.
So your plan is to dilate the circuit, and if it looks okay, just do a one-step strategy?
Yeah, maybe. It has to be look okay, really okay. I don't know. I like to make decisions
on the fly.
I don't know.
Keeps the suspense going.
I don't. I changed my mind. Okay. Let's dilate, go to 20. Okay, let's stay up. Should we go more distally also? I think so. Okay, down.
so even the circ dilation, the blood pressure comes down.
Okay, 20. Now we are almost only in the circle. Down, which is the, yeah, which is the, yeah, which is the circ wire?
Should be this.
Down. No. Let me go a little bit more distant. Okay. Go to 18. Can we see the, possiamo vedere, stay up, possiamo vedere la circonflessa nell'obliqua destra? Let's see in the areole the circumflex.
Adesso?
Adesso? To see how distal we need to go. No, il film,
il film.
quello che abbiamo.
Okay.
Let's see on the baseline. Ok, so andiamo in obliqua destra.
Just after the
yeah,
main
after
circuit.
we don't need to go too distant. I think
that's
it's enough.
fine. That's fine.
Let me get this wire a little bit.
there's a branch that divides, it bifurcates there. Okay, let's leave it like that.
Okay.
Should we get
Okay,
this balloon out?
Yeah, let's get the balloon out. Let's do another inflation here just to make sure. Go to 20. Balloon is well expanded, eh? Down. Okay, I think we can go to the LED stent.
Well, let's take a picture and make a decision. How about that?
But
I
now,
think if there's a big dissection in the circumflex, we should stent it now, right?
Yeah, but I think if we stay in the circle, I like to do a T. Okay, take pictures. Sure, looks beautiful.
Yeah.
Looks fantastic.
Oh, you want to do some drug-coated balloon there?
Maybe. Looks fantastic. Look, it's one of the best results I ever had.
And Tony, you were talking about 20 years ago. You were just doing before stents. You have a nice dissection of the LED, which would have been a success back then, right? That was the goal. You were trying to create those.
Yeah.
Yeah.
Yes, yes. I think I think we can go with the stent.
Which stent?
I think we can go 3.5, 3.5, 40, 3.5, 40. So this is called abluminous, is a drug delivery stent with only stenting toward the wall of the artery. Is supposed to have an advantage in diabetics, and we are doing a prospective study, randomized, with OCT checking in diabetics.
So yeah, we're going to randomize
versus,
luminous versus lines. The other advantage of this balloon, so it's sirolimus eluting with nanoparticles, but on the balloon is also a drug-coated balloon, right? So the theoretical advantage is the fact that, you know, even the gaps between the stent will get drug onto the wall, so you'll have more homogeneous sort of drug transfer to the wall.
So you get two things with one,
Yeah.
drug-coated balloon and drug-eluting stent. Can you believe it?
The other thing that will come up is we had a whole left main session this morning, and there was a lot of emphasis on the imaging. And I think at this point, you know what stent size is going to be. You just want to optimize it post. I don't think you need to do a diagnostic.
Yes, yes, exactly, exactly. We know that we're going to use a 3.5.
If you're going to put a 3.0 stent in the LED, then I think you need to do imaging before to make sure that you don't put the 3.0 stent. If you're, and there are a lot of times that other size stents can be placed. And obviously, there's different populations, different sizing, but you know, in the proximity.
Let's go in, andiamo nella craniata, let's go in cranial. We want to cover the ostium because
I think the cranial is a better view for seeing ostium.
maybe come back a little bit more. Let's take a picture.
That looks good.
That looks perfect.
Perfect.
You see, I
Perfect.
feel it by
Because
hands.
yeah, you could have done it with your eyes
I
closed.
feel it like this. Inflate. It's experience. Okay, let's go to 18. 18. We need to point on it, but it's well
Wow,
inflated.
that's very well dilated. I mean, I think we need to do a plot maybe on,
Yeah.
on the left
Okay,
main.
down.
But it's very well expanded.
Should we use a 3.5 for the left main?
3.5
Or
or 4?
four.
I think a 4. No?
Maybe. Let's do IBUS and decide.
Let's do IBUS.
Let's do
IBUS.
IBUS.
I think it's appropriate.
Okay, let's do IBUS now. Okay, I
Well, watch
remove
out the
this
stent
balloon.
with the guiding catheter.
Yeah. Andiamo, let's go to senza zoom, no zoom. Okay, so Azim told me to be careful with the guiding catheter, not to traumatize the ostium of the stent, the ostium of the left main, because the stent may be protruding.
And also we've got a jailed wire that's going to bias us a little bit towards the struts.
In this case, it's very important because these modern stents, they don't have the longitudinal strength of the old ones, so you have to be really a little bit more careful. So Sato is our excellent doctor from Tokyo, who's going to help us with the IVUS. Sato has been here for 2 years. He's really a great addition to our program. Okay, this is a Boston Scientific IVUS. We're going to start here. We have an old stent that has been there for a while. And pullback is going to start now. You see the IVUS?
Okay, let me start.
Yeah.
So here is the lesion we are treated with the previous stent. So base diameter 2.5 to 3, or we can see severely calcified lesion, but lumen looks nice. Previous stent looks well expanded.
Okay, you see the angio where we are doing the pullback. Lumen is fine.
Yes.
Lumen is very nice. Very symmetric even. I think
Okay,
here
so now
we're
in the new stent, yeah?
Yes, I think so, yes. So we can see some crack on the calcification. We can say it's some evidence of the lesion, nice lesion preparation with a lot of data. Lumen looks very circular.
very nice. I
Yes.
like that.
Here we can see some crack again. So far looks
Yeah,
very nice.
can we see the IVUS?
IVUS.
Yeah, just show the IVUS.
E l'angio piccolo per favore.
Okay, lumen is fine.
Yes. Even in the region with the severely calcified.
So we are, togliela nostra, it's okay, va bene. Okay, here we are in the proximal LAD.
Yes.
Mm-hmm.
If we see this side, stent looks
The lead-
already, yes.
Mi dà un pallone del 4, aspettiamo a aprirlo, lungo 20.
Anche più
No, anche
corto,
3.5, anche 3.5.
No.
3.5 e 20.
A branch
I
is
think
coming
3.5.
3 o'clock.
3.5, 20.
So this is the circle which we protected.
Okay.
Now we are
Here's
in
the
the
left
left main. Yep. The diameter is larger than 4, we can use it for.
Yeah, we can go 3.5, 24. It's
Okay,
going to be
yeah.
like 4.
We're coming to the ostium, and the ostium's well
Yeah,
covered.
Yeah,
Well covered
is well
with
covered.
minimal protrusion. Yes.
So let's post-dilate with 3.5 at 24 atmosphere. It's almost a 4. Maybe if we want, we can go with a 12-4, very, very ostial. And then we take a decision for the surf. Andiamo col pallone.
Sì.
After this final post-dilatation. My impression so far is to do a drug-eluting balloon on the circumflex.
Yeah, me too.
But we'll see. We may have to do another kissing inflation.
Valentina?
Mi dà un'altra universal intanto, inflate.
E portiamo in sala anche un pallone medicato,
Let's go to 20, 22,
2,5, 30.
24.
Three positive.
So this is a
Yeah,
3.5 at
3.5
24. Down. Sato, do you think we can go with the 4 in the left main? Ok, che mi dà un 4-0 12, 4-12, non compliante. Let me come out with the guide, ok. 20, 22,
24.
ok. down. We're going to go with a short 4 in the left main. Sì, non aspettiamo. Okay, after this we're going to take a picture and make a decision for the circle. Okay, let's go with the 4. But I think Rotablator did something. Yeah. Okay, you have the wire.
Yeah.
So this is a 4.
Maybe we'll get a show of hands from the
No
audience. How
comply.
many here, raise your hand if you think that the circumflex is going to look good.
Okay,
Raise your hand if you think that he's
go
going to
to
need to stent the
18,
circumflex. All right, so
20.
a little bit more for stenting than otherwise, but let's see.
But we have a high threshold to stent the circumflex ostium because we really notice that the restenosis is not trivial.
So that's 20, the pot with a 4O, 12 balloon at 20 atmospheres, okay?
Okay, I leave the balloon there to cannulate with the guide. Still a lot of spasm. Let's go, andiamo nella spider. Let's go in spider. Togliamo zoom, mettiamo zoom, let's put a zoom. Okay, a little, let me go with the piccolo test. Okay, that's fine. I think we do a kissing and then decide.
Okay.
Ready?
I'm still for black-coated balloon, I don't know. Let's open up the strap.
Ma let's do a kissing.
And we can always do iris on the second
Mi dà per favore un 3-0 semi-compliante lungo 20 pallone. Let's go with a 3-0 semi-compliant 20 balloon. E mi dà un altro indeflator, another indeflator, e prepariamo il 3.5 pallone che abbiamo già usato. So we're going to go with another wire, with the original, with the wire not trapped in the circle.
So especially because he has spasm at the wrist and he knows the guide is going to be a challenge, you always want to keep that jailed wire down the circumflex. It's a good marker, but it also can anchor the guide in, especially if the guide doesn't have good support when he tries to cross back into the circumflex.
I think a little bit, not on the stent, but a little oblique. Dammi una guida nuova per favore. Magari una Sion. Sì. Sion blu.
I need a, I think I need a new wire. It got damaged. With, I think we need a new wire. It got damaged through the stent. Let me advance the other wire. Okay. Can I have a new wire?
Yeah, here you go.
When you exit, togliamo questa guida. Wait. Okay. Okay. We need a, sometimes when you exit, the stent protrudes a little bit and damages the wire. Okay, let's get a new wire. Okay, so we have a torque on the trapped wire. Watch out, okay. This wire behaved quite good.
So that technique he just used to wire side branches is really important to learn. Basically, when he gets it, it starts prolapsing a little bit. The typical tendency for most fellows is to then
Which is the surface? Okay. Yeah.
What he then does, he gently brings it back and turns it ever so slightly, and then it goes down the circumflex. So
Okay. Il pannello 3, nuovo.
Ok, let's go with the balloon. Andiamo con il semi-compliant trio balloon on the circumflex and 3.5 on the LED. Ci abbiamo tutto. We have everything already. And then after the kissing, we make a decision.
No, questa qua. Questa
è la circumflexa,
che è un altro colore.
Let's go without zoom. I like to see the tip of the circumflex wire. Okay, it's fine. We have a safety pin. The cross is quite easy.
Yeah,
Yes?
that's very well.
Let's go. Let's start here. Not too high, just enough. We don't want to create a dissection.
This is not a triple-coated balloon. This is just a regular balloon.
No,
This is a normal balloon,
the
yeah.
trio normal balloon. Okay, down. Ok. Andiamo a un kissing, mi dà un pallone per l'IVA. Ok, down.
Just see how well it's
Okay.
inflated, please. Okay, so it's really well inflated. Yeah?
Ok, questa è l'IVA, LED. So we go with the 3.5 to do a kissing.
Pietro.
Steve, I saw in
Alla
the
guida.
presentation there was MR.
Tieni
It's
conto
moderate to
delle
severe,
dita
it's
prese
severe,
avanti.
and it's all functional. Is that correct?
Yeah, the MR was moderate. It's functional. There may be obviously an ischemic component. So I think our plan today was to, if things go well, also fix the right, and then we'll reevaluate in the future the MR.
Okay.
Okay. You want to go a little bit
Yeah, a
in
little
with
bit.
both balloons?
Yeah, a little bit in with the circumflex.
Okay. Good.
Okay,
And the LED is okay there?
I think it's okay. Okay.
Possiamo vedere?
Okay, so we are doing a kissing. What pressure are we?
We have 10 on both.
10 on both. Okay,
Okay.
down. You want to come back with the circle a little bit more and do a little bit of hugging on the left main. Okay, down. Okay, low pressure. Some people may criticize this hugging on the left main.
Yeah,
which
because they
people-
say the stent
It
becomes more
deforms.
oval, and it's not round anymore.
I don't give it then.
Non aprire, eh? No.
Okay, let's go. Let's come out with the balloons and take a nice picture, and this is going to be the one to make a decision. You see
Want
the
some
heart,
nice-
you
nice
see how
picture?
well contracting the heart, eh? You
Amazing,
see?
yeah?
Okay. I think it's improving the ejection fraction. Very, yeah.
I would just do a drug-coated balloon in the second pass. I have to admit.
That looks pretty good.
Looks pretty good. I mean, the AB group branch is
Yeah,
a little
it
pinched,
looks-
but the OM is bigger.
I will do a drug-coated balloon.
Yeah. I wouldn't stent it. I mean, so let's have a 3.0 drug-coated balloon. So we're going to use a Magic Touch. It's the same balloon that was on the Luminous stent. It's the sirolimus eluting balloon with nanoparticles. It's right now the only sirolimus eluting balloon we have in Europe that's CE marked.
And we're going to do an IVUS on the circumflex also. If we are not happy, we can always stent, but my threshold is not particularly
So,
low. So this is
yeah,
is
different
the
color wires,
circumflex,
so the darker wire.
So you're going back to
circumflex.
Which wire is on the circumflex?
I see on.
Cyan blue.
Mm-hmm.
So it's a little bit workhorse wire for some people. Okay, so this is a drug-coated balloon going in the circumflex.
And it delivers well?
Long 30 millimeter.
See now?
I think it's okay.
No, I think it's pretty good. I mean, we've been happy with it.
Inflated.
So do you have to
You think we are covering the ostium? Yeah.
going back across?
I think so. I think, let's say Midal 3.5. I think it's nice to do another kiss because every time you inflate, you may deform a little bit the stent. When we have time, we have to keep it up for 1 minute. Questo è il liver.
Sì, il 3,5 di prima.
Blood pressure is about 100. Let me close the. It's 100.
Yeah.
She feels. I
It
think
dropped.
we are occluding.
I think we're a bit, disrupting the flow in the LED too. So that's, I mean, you tend to need about 40 seconds only with this balloon. So that's 40 seconds.
Can you hold the wire?
Yeah, go ahead.
I'm advancing it. It's good to work with 7 French because it's not a must, but you really have less resistance, especially when you use non-compliant balloons, and especially if the balloon has been used, inflated 3 or 4 times. Why? I have some resistance
On
in
the
the
wire.
guide.
The wires may be crossed and with a used balloon. Want a new balloon?
Yeah, let's get a new balloon. I cannot advance the balloon.
We've used this balloon 3 or 4 times already.
Let's throw it away. Buttiamolo via. Yeah, ma anche semi-compliant. Semi-compliant.
Yeah, and that
Too
happens
big.
even in 7. It can happen, especially in the left main.
But but what the resistance was in the guide.
I think the wires are crisscrossed.
But before it went, we did not really change. But I think the non-compliant balloon inflated 3 or 4 times, especially at 24 atmosphere, really becomes bigger than an inflated stent. Okay, so this is a semi-compliant, brand new, 3.5. To do this kissing, then we take a picture, and then we do an IBUS. I think we may also consider an IBUS on the circle. What about the right? Do you think?
I think, he's come from far away, so we should do the right too.
We're going to treat the right off camera.
Yeah.
We take advantage of the impeller.
And the rotoblader.
You see how this balloon went? But we still have to go.
Strange.
Let me remove the other balloon.
Either that or the wires are crossed.
But before it went,
Because it's right at the bifurcation, right? Where the 2 wires separate.
let's do a gentle inflation. Go 6, 7, 8. Okay,
8.
down.
Because it's right where the wires separate. Yeah, but
Okay, you see, it's okay. Sometimes some gentle persuasion. Okay.
If that doesn't work, just push like hell.
Okay, let's go back with the drug-coated
Go a bit
balloon.
further. Let's get it, spark it a bit more distal as you can.
Let me take guide in a little bit better. Okay, you see. It's fine. Let's do a kissing.
Good.
I don't know, those sausage right there. It's like a sausage. 30.
Yeah, the DCB is 30.
I think it's okay.
Let's do an IVUS. And
Okay, let's do an IVUS. Take a picture. And the other interesting issue that we noticed with the impeller is that if the patient has a high creatinine, usually may even get a lower creatinine at the end of the procedure. I think you get an improvement in renal.
Some smaller data that suggests that. I mean, it's not, that paper that was published in Certain Research is relatively small, and there's imbalances between the groups. But it definitely, I mean, if you don't have hemodynamic perturbation, you don't
Okay, let's take a picture. We are a little bit in with the guiding catheter, but enough to take a good picture.
That looks great.
looks great.
Okay, I think the ostium of the circ is not perfect. Vediamo.
Let's see the picture. I need an IVUS.
Let's do the IVUS first on the circ.
Okay.
But LAD looks fine, left main looks fine. I think it's really amazing how, if you are careful with good reasoning support, PCI really becomes a very predictable procedure.
Yeah, yeah.
How much contrast have you used so far?
Quanto
Just under 100.
So in terms of doing the right,
But was
we're
about
discussing,
80? Yeah.
the RCA, what are your thoughts?
I think it's okay. We can do the right with very little contrast. We have used more contrast than what we are used to do, just to show you something more. But normally we would have spared some injections that we did. Okay, the IVUS went down pretty easily.
Okay.
Right, the lumen looks fine.
Lumen is very nice.
Yes.
Right? So we have to pay attention to the ostium, but even
Yes.
if there is some pinching, it's so focal that may not be functionally significant.
A lot of calcium, yeah.
Yes.
We are
Yeah,
in the
looks-
still
yeah.
distal, huh? But lumen is decent. Eh?
Yes, yes, I think so. Now branch is coming.
Not bad. Eh?
So far, there are no major dissection. Lumen looks fine. Now another
And the
branch.
residual lumen is fine.
Yes. Now LED is coming. Yes. The result of the kissing balloon looks perfect. So let me measure the area at the psychostimulator. Here we are in the
This is
left
the left
domain.
main?
Yes.
Yeah, it looks
We
much
post
better.
our-
Let's
yes.
see the ostium.
Much larger. With minimal protrusion to other.
Looks great.
Yes.
I think it's fine.
Yeah.
That's right.
You want to take a cranial? We have to do an IVUS on the LAD, but
I think the IVUS already,
I
right?
think we already did
Yeah,
it.
we just needed to check the left main because we after the pots and so on. But I think, you know, one last picture, so we have some contrast left for the right.
Ponti? So that, what you think is an indentation? What is that?
I think we're not well cannulated, right? So we're under the stent. Because on the iris, the ostium looks perfect,
Talking about
right?
the ostium
Yeah.
of the left main.
Of the left main, yeah.
I think it's just an image due to
The fact, I think we're under the stent, we're not cannulated well, and so...
Eccentric calcific plaque where if on the iris you can see it. But I'm sure your area is fantastic.
And this is just, can we show the iris?
Yeah.
Sato, just show the ostium again so everybody sees it. The ostium of the left main.
Left main, okay.
Yeah.
See, it's
So let me
that
start from here.
eccentric calcific shelf there.
Yeah, it's from
Yeah. Yeah.
Yeah.
It's probably that we're seeing.
let's see the iris.
Yeah.
I think it's okay.
I think it's great.
Yeah.
I think it's okay.
Better
Let's take
clarify.
a quick peek on the right. We still have 8 minutes.
Mirare la guida allo scambio. È una guida 6 French per la destra.
Yeah.
Bene.
Diamo un obliquo alla sinistra.
At the sarcostem area was 5.7.
Okay, so
5.7.
Sato measured the area of the
In la
circumflex
guida?
ostium. It's 5.7.
Yeah.
RJ, so I think that's pretty good.
Now the one thing that can be sometimes
Okay, we're gonna
challenging
take
is with the impella and the positioning of the impella, it can sometimes impede your ability to get into the right coronary artery, and sometimes requires manipulation up and down to be able to do it. But I think you'll be able to do it. Go 6 French to avoid the spasm.
Yeah.
Yeah, I think the idea to use 6 French it improves
Yeah.
maneuverability, especially when you go to the right.
Questa pressione dove nella
Impella è stable 3.5. Quant'è il flusso?
3.4.
3.4.
Vieni.
Okay, so this is
Facciamo vedermi
a
la
regular
mela.
Jackin's right,
Completamente stabile.
guiding catheter, 6 French.
The decision to stage versus not is always one that comes up, but Antonio said that while he has the impella in, as long as the contrast situation
Yeah.
is controlled, you can use that to your advantage. Otherwise, the EF is still going to be low, and then when you come back to the right, if something happens, you don't have the support, and you don't want to use the device twice.
But if you do come back, you would also, would not
Yeah.
be sold the vessel at that point, so you could argue balloon pump support at that point as well.
Yeah.
Okay, or maybe even
Mi dai una guida
flash,
coronarica?
flash, okay.
Sì. E il microcatetere anche?
You can see that the right is calcified.
Yeah, very calcified.
Microcatetere?
Small test. Let's take a picture. I think we may need a rotablation for the right as well.
Definitely. So we're going to go down with the microcatheter again here and a workhorse wire and then exchange for our rotor wire.
When we rotablate the right, what we give to prevent bradycardia, aminofillina.
Una
Diamo
fiala? 15
Oh, he has a pacemaker. Okay,
Yeah, so he doesn't
has
need it.
we don't need aminofillin. So he has a temporary permanent pacemaker. Okay, so we're going to do the same. We're going to go down with the universal over a microcatheter, fine cross, exchange to the rotor wire, and ablate with the 2.5 burr.
Devi cannulare, non siamo.
Let me go with the microcatheter more. I think
No, questa è no.
we are in the aorta.
Anche verso il microcatheter.
Okay.
You want to cannulate
Let's see.
and I will get the wire down.
Small test. We are not selective, but We may need to manipulate the guide a little bit better. You want to manipulate, or you go with the wire,
No, you manipulate.
and I manipulate the guide. Okay, try now. Okay, it looks fine.
That's a branch, I think.
Okay, watch out. Let me go with the microcatheter.
Oh, no, that's he's the right, sorry, he's the right. That's all the calcium.
Okay, continue.
So while the microcatheters work,
We are still in, yeah.
for these types of cases, they're so invaluable
Yeah,
because you can't torque beyond the calcium otherwise. And over the wire balloons are just not, you can use them, but they just don't have the same performance characteristics.
Yeah. Over there? Over
Do you
there.
have any hesitation about rota?
Especially,
And when you do rota the ostium, your wire choice is still the floppy?
yeah, still we always use the floppy. I think is enough.
Rotablator
Okay.
frontal.
Rotablator wire. If we get disconnected, I really thank you, all you people, for this opportunity. Thank you for the nice comments and suggestions. We are really very proud and happy to be with this almost year event with India.
Yeah, Antonio, you've been doing this
So
transmission
this is-
this year for a long time, and we really appreciate all the teaching and learning that we can get out of this. So thanks so much. I don't know if we're going to get cut in the middle, but if we do, it's a fantastic, fantastic demonstration. Very, very tough case with total calm, able to revascularize completely this patient.
Okay, we can go with the rotablation. Let's go without the zoom, togliamo il zoom. I like to use less zoom if I can, because I will lower the radiation to the operator and to the patient, and especially not lose control about the distal wire, which always stays into the field. Okay, we go with the 1.5, and yes, sir.
So, Azim, Antonio, we have another 5-10 minutes to see where this goes with your RCA, so take your time.
Ah, fantastic. Thank you. Bring us extra
So,
time.
what we have after rotablation, from up to where are we going to rotablate the RCA?
Up until that curve and that marginal branch.
What about distally? Let's get a cranial view. Possiamo fare una craniale?
You're going to go to that mid
Yeah, that's a...
Yeah, I wanted to go stop at the mid-artery branch.
Mettiamo lo zoom.
Antonio's wondering if we need to go all the way distal.
Ok, ready? Let's check, vediamo se siamo dentro, piccolo test. Ok? Ready? I
Yeah, I
think
would
we
stop
stop
at the
at the mid.
artery
I
branch,
agree. We stop.
Yeah.
It's a big right.
Yeah. It's a huge one.
Okay, let's go to the, we are in Dynaglide. Let's put, let's open the brake. Togliamo lo zoom. Ready?
Okay. And Dynaglide it. Are you done?
I
I
lost
wonder,
it.
has anyone, have you ever seen or had it burr onto the impella? Because they look pretty close.
What did you say?
Have you ever seen the burr interact with the impella device? For this
Not yet. No, have you seen it?
No, I just, it's appearing to me, the way the two look so close together. We have not seen it.
Okay. Let's.
For the audience, we know
Okay, we are ready.
what do you do differently for osteal lesions in terms of coaxiality or just what you're doing? Is there anything different that you're looking at? Any concerns you have specifically there?
No, try to be coaxial, but
In this case, it's kind of impossible to be coaxial because we can't cannulate. But I think the important thing is making sure that the wire doesn't prolapse at the ostium as you're going through.
so now I need to gain length. So what I do, I go down through
What's
the
the
wire.
guide is
Let me
the
turn
guide is-
the guide a little bit. Okay.
okay, good.
Let's go in activating.
What's the guide?
Okay, let me go with the guide. Let me turn the guide a little bit more. Let me activate. Huh? That's maybe
Okay.
enough.
Yeah. Well, I think that's where we wanted to go to. All right?
Slowly now.
Fai vedere la pressione generale.
A little bit deceleration there.
Did you run out of length there, Antonio, or do you have enough length?
No, now I have enough length, but what I did, can you
Stop
show,
Raggi, stop Raggi.
faccia vedere questa macchina qua, può far vedere questa?
Qua?
Yeah.
Over here?
Yeah.
Okay, if I run out of length, I come back with this up to the end. Then I take everything as a unit and I advance and then I
Yeah. Yeah, and I'm releasing the brake because otherwise, if you don't release the brake, Antonio's going to have difficulty sliding forward over the wire. So I release the brake and hold the wire.
hold the wire,
Yeah.
the wire.
So I
It's
release
very
the brake and hold the wire because if you don't hold the wire, the wire will flip backwards or
spin
forwards and
may
spin.
dissect. Okay, let's remove the rotablation. So this is a very important trick. Break open and wire held. Otherwise the wire spin, and we had cases where we had distal dissections, which is no good.
Okay? Go
Okay,
ahead.
ready?
Yeah. Well, we just want to show you an image, hopefully. Maybe dilate once and show you an image, I think.
No rush. It's going to take longer than that.
Hold the guide. See. That's
Press the
right.
vascularization effort.
Keep on coming back, almost there. Ok, we are out.
Okay.
Togliamo lo zoom, no zoom.
You want to exchange the
Piccolo
wire
test,
or
but let's take a picture for them.
let's
Small
show the
test.
complication?
Okay, ready? Pronti?
Okay, good.
Yeah, very nice.
Good.
This is without zoom. Everything is open.
Yeah.
Distal flow is excellent. Okay, I think we can say hello, so we can
say our
do
goodbyes, yeah.
a soft cut, not a hard cut. Grazie, thank you again. I wish you a good weekend for all you guys, and thanks to the whole team, Valentina, everybody for helping us through this case.
Thank you.
Thanks, everybody.
Transmission.
Thank
You're really fantastic. That's great stuff.
Oh, buono,
So we're going to move on to our last lecture of the previous session. Dr. Akasaka is going to talk about the benefits of imaging. How do I select patients for OCT to improve clinical outcomes?
Thank you, Mr. Chairman, and dear delegated discussant, and also the ladies and gentlemen. It's my great honor and pleasure to be here today, and also that I appreciate the kind invitation. Could you show my slide? I can see my slide, but not on the screen.
Can you project the slides? I'm seeing them on this screen, but not on the main screen.
I can see. Okay, thank you. I appreciate, right? This is my disclosure. As you know, this is an OCT principle. OCT is very similar to the IBAS. Yes. We use an infrared light instead of ultrasound, and this light goes here to one goes to the vessel and one goes to the difference, and then make a coherence and get an image. And this is OCT. How to get an image by OCT? At the time of angio, you insert the wire and then insert the fiber, and then during angiography you can get an image 5 centimeter or 7.5 centimeter per 2 seconds or 3 seconds. It's quite easy to obtain the image, as you know very well. And then this is one of the examples. As you know, there are 3 markers in OCT: the distal tip, and second is lens marker, and there are some another marker, 5 centimeter proximal to the lens marker. It is very important because in this case, target region is an ulceration, and the other region can be identified in the proximal RCA. If you decide the 5 centimeter product, it is not enough to identify the proximal region. Then we decide 7.5 centimeter product, and during angiography we get the clear image. And initially you can identify the cross-sectional image and also the longitudinal image at the same time. Here you can identify the ulceration. And if you put on the 3D reconstruction, you can get 3D image within a few seconds. And then further development can be demonstrated today. We can use the stent reconstruction, and also this is one of the examples here. I moved the cursor to the distal portion, and you can identify the position of this is an angio co-registration. You can identify cursor position by this marker on angiography at the same time. This is angio co-registration. It is very useful in a daily clinical practice. And then we can demonstrate the stent condition as shown in this slide. We can demonstrate the stent and also the apposition condition by the color. Red color demonstrate more than 400 micron incomplete apposition, and yellow color demonstrate 200 micron incomplete apposition. You can check the incomplete apposition automatically by using this software. It's quite easy. Based on this development, our practice a little bit changed compared with previous condition. As you know, in Japan, we always use guided imaging at the time of PCI. Previously, IBAS-guided PCI is more than 90%, but after development of OCT, as shown in this slide, in our institution, only 20 to 30% use an IBAS guide in case with an left main orifice and RCA orifice and CTO cases. Almost all regions except for CTO or other region, we use an OCT guide, nearly 70 to 80%. How to decide the landing portion? This is a stable effort angina case. Initially, we speculate a region length nearly 26 millimeter. This is a proximal landing zone. You can identify the 3 vessel normal looking area. This might be the ideal. However, in the distal portion, you can identify the lipid-rich plaque from 6 to 11 o'clock. So nearly 2 quadrant lipid may increase the H-rich stenosis. Then we try to identify the much better portion within 5 millimeter. This might be the much more stable. You can identify calcium and some plaque, fibrous plaque. This might be ideal. Then the stent length should be 28. And then if you put a stent, you can get a good result. Why we avoid the lipidic plaque as a landing zone? As shown in the right-hand side, if we put the stent at the site of lipidic plaque, more than 2 quadrants especially, this stenosis rate is significantly higher than the other plaque as shown in this slide, fibrous compared with fibrous or fibrous calcific or normal. So you have to decide the landing zone by using OCT. This is much more detailed analysis. The lipidic plaque more than 2 quadrants makes much higher this stenosis rate as shown in this slide, even in proximal or distal. And this is a multivariate logistic regression analysis. There are a lot of mechanisms of the stenosis. However, the lipid-rich plaque is the most predictive value for speculate this stenosis. Also, the minimum lumen area is another factor to predict this stenosis, as shown in this slide. This is another case. You can identify percent diameter stenosis very easily, and then we decide the reference site, and then put a stent. You can easily identify the result, and still in this case, the area stenosis is 21, and it is not enough. So you try to use bigger balloon and higher pressure in this case. So we try to get an MLA more than 90% of the average reference lumen area, but sometimes in the real clinical practice, it might be very difficult, especially in case with complex lesion. There are lots of recommendations of OCT use. There are lots of expert consensus documents as shown in this slide. And this is one of the examples of a single center retrospective study. If you use the OCT compared with angio guide, you can reduce death or cardiac death or other MACE compared with an angio guide as shown in this slide. And why we can expect this result? This is one of the explanations. Compared with actual phantom model, OCT is very accurate in the measurement compared with other modality. I was always overestimate, and in real practice, I was also overestimate compared with OCT, and QCA underestimate compared with OCT as shown in this slide. And also the reproducibility is very nice in OCT compared with IVUS based on this report. And recent development, as I already explained to you, we can easily identify incomplete apposition by color representation. And the red color is more than 400 micron, this incomplete apposition. So if you find these findings, you try to dilate proximal site using a bigger balloon or higher pressure, as you may expect. And because if the incomplete apposition distance is more than 350 micron, you may have an incomplete apposition long after stent deployment. So the incomplete stent apposition distance is less than 305 micron in years. It will disappear 6 months or 8 months after follow-up. That is enough. And we already demonstrate the OCT-guided PCI is non-inferiority of the OCT-guided PCI compared with IVUS in opinion trial in European Heart Journal. This is a protocol. We divided 1-to-1 OCT guide and IVUS guide. We follow up the 1-year clinical result, and we succeed to demonstrate the similar target vessel failure, and secondary endpoint is very similar. So OCT guided PCI is non-inferiority to IVUS guide. And another study is Illuminate 3, as you may know very well. Based on this data, they succeed to demonstrate non-inferiority of OCT compared with an IVUS guided. However, they failed to demonstrate the superiority of OCT compared with angio guide. Then they tried to demonstrate the superiority of OCT guide compared with angio guide in Illuminate 4. The study population should be much more greater than the Illuminate 3. This is the protocol of Illuminate 3. They try to differentiate the patients 1-to-1 in IVUS and angio guide and OCT guide, and they succeed the non-inferiority of OCT compared with IVUS guide. As I told you, before. So we are expecting the OCT guided PCI become at least 2A recommendation. And this is an OCT in case with unstable acute coronary syndrome. You can identify the thrombosis at the MLA site and plaque rupture a little bit proximal. This is a still frame. Longitudinal view can be identified similarly. Here is an MLA site. By angiography, we saw this should be the carpet lesion. However, the true plaque rupture is a little bit proximal. This plaque rupture make a flow disturbance and make a thrombus at the MLA site. So when you treat, even in ACS case, similar to this febrile angina, you try to identify the distal difference first and then proximal difference. Then here you can identify more than 2 quadrant repeat plaque from 3 to 9 o'clock. Then we try to select a much stable portion and then we put a stent, as I already explained. In case with ACS, if you use an OCT, you can identify plaque rupture nearly 60 to 70%, and plaque erosion in 25%, and residual might be the calcified nodule as shown in this slide. And almost all cases, you can identify the thrombus. Red thrombus demonstrate the protrusion mass with shadow, and white thrombus demonstrate the protrusion mass without shadow, and also we can identify the mixed thrombus. And further importance of OCT is some special condition. This is a case with a chest pain in 44 years female. Initially, we speculate vasospasm, but we cannot identify any abnormality by angiography. Then we did an IVAS. IVAS demonstrated some dissection, but we cannot obtain a clear condition. Then we did an OCT. Here is a true lumen, and this is a false lumen. Fiber is ideally in true lumen in the distal portion. However, this comes to the false lumen and then true lumen. If we put a stent here, we close the true lumen. Then we try to get a true lumen using a different wire. Here is a different wire. The different new wire is in the true lumen here, right? And then we can put a stent because the patient is unstable condition. This is a still frame explanation. Okay, I try to skip here. And after putting a stent, we can get a bigger true lumen area and smaller false lumen area. There are still some false lumen, but it will disappear short after follow-up. And this is a still frame explanation. And the advantage of OCT has been already published in literature from a Spanish group. And the incidence of spontaneous coronary artery dissection is depend on the diagnostic technique. Angiography underestimate, and the OCT is the best to identify the scab. However, you have to pay attention to the increase of the dissection, similar to the angiography if you use an OCT. This is another case. This is a very severe calcified lesion after CABG, and patient have a new disease. You can identify the significant calcification from proximal to the distal RCA. And Dr. Colombo demonstrated a very wonderful example of the rotablator in similar case. And this is an IVAS. IVAS can identify the calcium. However, we cannot identify the behind the calcium because of the shadow. But OCT can clearly demonstrate the thickness of the calcium as shown in this slide. Distal portion identify the calcified nodule and 360-degree calcium in the mid portion and the proximal portion. At that time, we try to use a rotablator for the lesion modification before putting a stent, right? And here is after rotablator, you can easily identify the ablation portion, and you can select the bar size based on these data. And if the thickness of the calcium is less than 500 micron, you can make a crack using a higher pressure as shown in this slide. And if you succeed to make a crack, you can put a stent and better result. This is a result if you succeed to make a calcium fracture, you can get a bigger minimum stent area and a good stent expansion index, and it makes lower binary stenosis and lower target region revascularization as shown in this slide. So the cutoff value of the thickness of calcium to make a crack might be 500 micron by ROC analysis as shown in this slide. And so the PCI for bifurcation region is also the very important. Bifurcation region PCI might be 15 to 20% in all daily clinical practice, and a higher risk for complications such as branch occlusion, stent thrombosis, restenosis has been reported more frequently, as you know very well. And we cannot select the position of link. However, if there are no link at the side of side branch orifice, it is very good. However, if you identify the link, the result is really poor. Recent advantage of OCT clearly demonstrate 3D reconstruction of the stent strut and wire position as shown in this slide. And this is one of the case of link-free type. There are no link at the orifice, and the wire is distal cell, and you dilate by kissing balloon, you can get an optimal result. However, if there are some link as shown in the green circle, if you dilate, you still have lots of stent strut at the orifice of the side branch, and this is a suboptimal result as shown in this slide. So if you use a 3D reconstruction in daily clinical practice, the wiring can be yes, expected nearly 30% cases again, and this is one of the Japanese registry, 150 bifurcation region. We identify the link-free time and link connection type, and the result is optimal, nearly half. I agree, okay, I will finish soon. And suboptimal results demonstrate a higher jailed strut volume as shown in this slide. We failed to demonstrate the clinical importance, but the link connection demonstrate the branch jailed strut volume as shown in this slide, and guide wire position and angle. And here there are tendency of incident restenosis significantly higher in suboptimal. But we failed to demonstrate the statistically significance because of the lower number of the application. I try to skip the instant restenosis because previous doctor already demonstrated. So this is my take-home message. Similar to IVAS, OCT-guided PCI should be useful to improve the result of PCI and clinical outcomes, and at least Class A recommendation might be expected in OCT-guided PCI in the near future, although there are several advantages and disadvantages in IVAS and OCT. OCT can replace IVAS in almost all cases in daily clinical, except for the several specific conditions such as left main or RC orifice, or CTO or CKD, and so on. OCT may have advantage in PCI for ACS, incident restenosis, several calcified region, and 3D reconstruction may improve bifurcation region stenting. Thank you very much for your kind attention.
So that was a wonderful overview on how to use OCT. I think in the interest of time, we're probably going to stop this session, take a quick 10-minute break, and come back with the other sessions after that. Thank you.
I think we'll all break for a quick lunch, and within 15 minutes we'll try to reassemble back by 1:45 here so that we can save some time. I request all of you to have a quick lunch and assemble back in 15 minutes. Thank you.